Okay, all right. So, hello everybody. Thank you all for coming. Let's just start off by having a quick chat about the rules of the day. So, wanted to quickly let you guys know about how the day is going to go. So Fatima Saleh is our speaker for the day. She's an F4 working in Northwest London. We're going to be collecting questions throughout the two presentations she's doing. And then we might be having a Q&A session in the middle between the two as well. It'll be up to her and her timings. We sadly do not have either the MDU or the BMA with us today to have a chat with us, but we'll be going through how the how the MDU can help you. Next slide, Fatima. So keep in mind that your MDU Foundation membership needs to be applied before you start shadowing. Unless you filled out the application, filled in a foundation application form, your student membership will cease in the summer. It's essential you have indemnity cover, so check out the sign up links, which I'll throw into the chat in a second. Contact, and I'll give you an email if you have any queries. All right, and over to Dr. Saleh to start their talk. Hang on, sorry, Fatima, I think you're muted. There we go.
Hold on. Better now? Yep. So there is a sweet and salty course that is held by the Mind the Bleep team. It's really good. It's an online course, and we're actually offering you the chance to win a place on it for free. All you have to do is just enter on the website on the screen right now. We'll put it on the chat as well, but I'd highly recommend it. It's free to put your name in for it, and it's a draw, so we'll let you know as well who's won, but I would say go for it. Right, so we'll start the talk now. So today we're talking about referrals and requesting scans. First I'll do a little talk about referrals and then we'll do the other one. So just a quick overview. I'll do a little introduction, tell you why it's important, that you need to know how to make a good referral, and then we'll go into the nitty-gritty, what you need to do before making the referral, how to actually make the referral and what tools you can use, and then dealing with the aftermath. So what is a referral? It's when a team basically requires input and asks for that input from another medical team. And it can be advice, it can be asking them to take over patient care, it can be about organizing a review, inpatient review, outpatient follow-up, etc. And it's usually done over the phone, but sometimes through electronic means or paper, but regardless, the principles will remain the same, regardless of the mode of communication. So why is it important? It's obviously going to be part of your job as an F1. You are part of the junior team and you are expected to act upon whatever is requested by your seniors on the morning ward round. So that's why you need to know how to do it effectively and successfully, hopefully. It's also important to maintain patient care. So it's essentially you accepting that you're not in the best position and there's another team that's better placed to aid with a certain aspect of that patient's care. Finally, it's something that can be quite challenging. You're an F1, you're new to the job, and you're going to be speaking to a senior in an unfamiliar specialty, and it will usually be a registrar, but can sometimes be a consultant. But fear not, because that's the point of these presentations. We'll try and give you tips on how to make sure that it's not as hard for you to make referrals. Hopefully you'll come out of this and it will be quite manageable thing for you to do. So getting into making a referral. Before you make the referral, there are a couple of things you need to think about. First thing is the purpose. Why are we referring? What exactly do we want from the team? And if you're not quite sure, then they definitely won't know. So you need to always never be afraid to ask your reg, can I just clarify what exactly do you want from the team? Is it advice about X, Y, and Z? And how quickly do you want that advice, for example? The second thing is you need to make sure you've got the patient's demographics and their background. You need to know their hospital number, you need to know their name, you need to know their location, and you need to know what's gone on since they've been admitted. Third thing is that you need to prepare. So we'll give you tools for that in a minute, but just as a general, try and think about what you're going to say. And there's nothing wrong with writing it down even before you call, just to help you structure it better, or if you're a bit nervous. It's certainly something I still do if there's been a patient who I've not seen that much and they've been in the hospital for months and months and months, just so I can make sure I've got all the information. Fourth thing is, sounds probably quite obvious, but make sure you're contacting the right person. Sometimes, you know, teams might be composed of a cardiology reg that handles ward stuff, and their patients, and there might be another reg that handles referrals. So it's things you'll pick up on from your colleagues. You can ask them once you start your new job. And making the actual referral. So again, sounds obvious, but check you're speaking to the right person when you call. Just a quick, hi, is this the anesthetic reg, or is this the cardio reg? It will save a lot of heartache and time, probably for both of you. The next thing is definitely introduce yourself. Say your name, say which team you're from, and the level you're at. You can say, I'm one of the juniors, I'm one of the F1s. And the third thing is, we tend to in the UK use specific frameworks. So the one that is commonly used is called SBAR, and we'll be giving you examples of that. But just to, in case you're not familiar with it, SBAR is, as I said, it's a structural framework. It's a communication tool to effectively communicate, escalate problems, and to enable referral processes to be done smoothly, quickly, and clearly. So I'll just go through that briefly. So each letter in SBAR actually stands for a certain aspect of your referral. So S stands for situation, and in that part of your referral, you're going to identify yourself and identify the patient, and you're going to state the reason clearly why you're calling. They need to know right at the start. Then you'll go into background, so presenting complaint, past medical history, and relevant investigations and treatment. Doesn't need to be the most extensive thing, but everything that's relevant. Next thing is assessment, so observations or OBS, or you know, depending on where you are, you might call them vitals. One good tool to use when trying to relay someone's OBS generally is the news score. So that's used widely in the UK, but not necessarily every hospital, and probably not so much internationally. So it just for a quick kind of overview, it stands for National Early Warning Score. And it's basically an aggregate score based on scores given to individual parameters like heart rate, blood pressure, and the score is based upon how much they deviate from the normal range. And it's been something that has been shown to improve detection and response to deteriorating patients, hence why it's used so often. And it's a chart that you'll find in the bedside notes of patients usually, if you're still using paper-based systems in the hospital you're at. The next thing is you give your own impression and your concerns. So you can tell the person over the phone, I think they've got this is why I need you to come and see them. If you're really not sure, then you can still sometimes say, oh, I'm not sure, but I'm quite worried because of whatever it is that's going on with that patient. But generally, you should have some idea. Recommendation is the final part. So that's where you reiterate your request with an appropriate time frame, and you can make suggestions, ask them if there's anything else that they can do to help, that you can do to help, sorry, to facilitate the referral. So just going to go through some examples for you. So the first case is an example of a referral to the anesthetics team. So I'm just going to get my colleague Av back on. He's going to pretend to be the anesthetics registrar, and I'm going to be calling him as the F1. So I just want you to kind of listen out for, this is a bad example, I should say. just to make it obvious to you the difference it can make. So he'll give me feedback as well, I'm sure. So I'm just gonna go on the next slide, and if you can't see it, I'll be saying it as well. So ring ring.
Hello?
Hi. Is that the anaesthetic registrar?
Yes, it is. How can I help you?
Hi. So I'm from general surgery, and we have a patient who's known to you who needs an anaesthetic review for surgery. He's very unwell. Could you come and see him now?
Oh, hang on. So you're from general surgery. Who are you specifically? You the reg?
No, I'm one of the F1s.
All right. Also, I don't know who this patient is, so I'm going to need to find out a bit more about that. You just say that he's known to us, but I know an awful lot of patients, and you're saying he's unwell. I've got four other patients to see, and including a couple of people that just need simple access. So I need to know really how unwell he is, so I can figure out when I should be able to come see him. All right. Why don't you go ahead, reassess the patient, do an ATE,
Mm-hmm.
come back to me, and then let me know a bit more about the patient, and I'll see if I can come and see him for you. Okay.
Okay, thanks,
All
I
right. Bye bye
guess.
now.
Bye. That is a fairly typical exchange that you could have, and it can be uncomfortable. It's a waste of everyone's time, and you can clearly tell from this example there's a lot to be improved upon. So now I'm just going to do basically going through each of the S-bar components, and I'll demonstrate perhaps a better example. So again, listen out for the things I mentioned, identifying myself and the patient and stating the reason for my call. So this time it hopefully will go better. So I'll say, hello, my name is Dr. Galaxy. I'm one of the general surgery F1s. I'm calling on behalf of my consultant, Miss Oreo, who has asked if you can kindly review one of our patients, Mr. Quality Street, NHS number 1234, Ward 4, Bay 3, Bed 2. He's a 75-year-old gentleman who we plan to operate on today under general anaesthetic for a right obstructed inguinal hernia. So I've put that on the next slide as well, so you can come back to it. And straight off the bat, I've mentioned who I am. I've said who the patient is. I've given the details of the patient, location, number, and I've said that we're going to operate. He's going to go for his hernia repair, and I'm asking for a review. So that's that section done. Then we'll go into the background. So mentioning the patient journey. So again, I'll carry on and I'll say he presented today with sudden onset, right groin pain and nausea, but no other obstructive symptoms, on a background of known right inguinal hernia. And on examination, there was a 2 by 3 centimeter tender, irreducible right groin mass with no overlying skin changes. He had bilateral total knee replacements under a GA for osteoarthritis last June here, and has no other past medical history, drug history, or allergies with unremarkable bloods. Again, I've just put that up and I've highlighted the key bits. I've said when he presented, I've given the background, and really important, it's so common to hear people referring and saying, oh, this patient's known to you, but it's not as useful as you might think, because teams change all the time. Even if they don't, they're not going to remember a patient that well. So I'm giving context in this example. I'm saying he's had bilateral total knee replacements for osteoarthritis last June. So this is more helpful to the anaesthetist. They can look up their own records and it will just make everything much smoother. And then I've also mentioned past medical history and investigations. So next I go to the assessment. So again, OBS or vitals and my impression. So listen out for those. So I'm saying he's currently clinically well with a new score of 0. He's been reviewed by the consultant and consented for laparoscopic repair of the hernia, and he's been nil by mouth since 8 a.m. So again, up on the slide, I've given the new score of 0. So the anaesthetist knows that he doesn't have to kind of rush here to get here and see the patient. It helps them prioritize. And important for such a referral to anesthetics, which again, you'll pick up on what kind of things they're looking for. He's been consented and he's nil by mouth, so he's good to go for a surgery. Recommendations, the final thing. I'm going to make my request again, reiterate it, and I'm going to give the level of urgency, so when I expect him to be seen, and I'll make suggestions. So I'm going to say, we think he needs urgent surgery and would appreciate an anesthetic review as soon as possible to determine fitness for surgery under a GA, as he is next on our list. So clear request. I'm saying he's next on our list. You need to come see him soon, fairly soon. And I've ended by saying, I have already sent 2 group and saves. Would you like me to do anything else in the meantime? So again, something important to anaesthetists is the group and save bottles are sent. And then I said, do you want me to do anything else? It will help everything go quicker. And he might say, you know, do an ECG because the patient is older than a certain age. But you can clearly see between that first example where I was told off by the anaesthetist, quite rightly so, and this one, obviously it takes more time to construct this and you need more information for it, but it's much better to spend that time and save time effectively, because then you're not having to go back trying to read through everything. Also, never make things up. So like if they say, oh, but how is the patient now? How do I know? Don't feel pressure and on the spot to say, oh, I think they're okay, because that can land you in obviously a lot of trouble and the patient as well. So make sure you know everything before you make the referral, or even have your patient notes in front of you, have the computer screen up in front of you in case there's something you want to clarify while you're on the phone. So I've got another case, just one more to illustrate the example. So this is a referral to the respiratory reg, and as I can see, Ab is keen to grill me on the bad example as well.
I'm ready.
So ring ring.
Hello.
Hi, is this the respiratory reg?
It is. How can I help you?
Hi, my name is, I'm one of the, sorry, I don't even tell you my name this time. So I'm one of the general surgery F1s, and we have a medical patient who my consultant says you should take over. He's got a community acquired pneumonia and our team just can't manage that. He's on bay 7, bed 6.
All right, that's interesting. I love that you said that you're not going to tell me who you are. That's a great air of mystery to the whole thing. Also, I don't know who the patient is. I don't know where the patient is. Don't know what's going on with this chest infection, because if you're saying pneumonia, I mean, loads of people can have pneumonias outside the hospital. So I want to know why the specialist respiratory team needs to get involved in this pneumonia. And I appreciate the fact that your consultants reviewed this patient and thinks it should be under the respiratory team. What I'm going to do is you're going to get some more information for me, and then I'm going to figure out when I'm going to review this patient to be able to say whether or not I am taking over care. All right, because you can't just call up and say, this guy's got a bit of a cough, take over, please. We need to do a bit more than that, yeah?
Okay, all right then, fine. I'll call you a bit later. Thanks.
Bye-bye.
Bye. Thanks, Sam. So this is something that your seniors might just say, oh, call the medical team, if you're on a surgical team, for example, and tell them that they have to take over. We don't manage this kind of problem. And that's, first, it's discourteous. It's not the way things run, and you will probably get a worse response than Ab just gave me. So try to construct it in a better way and articulate it such that they can't refuse the referral. So again, I'll go through the examples again, listen out for the specific things I've put up on the screen. So situation, identify myself and the patient, and the reason. So it goes like this. Hello, I'm Dr. Galaxy, one of the general surgery F1s, and my consultant, Mr. Yorkie, has asked if I can refer one of our patients to your team for takeover of care. It's regarding Mr. Kinder Bueno, NHS number 5678, ward 8, bay 7, bed 6. He's a 68-year-old gentleman who presented with signs of sepsis and has a CT-proven community-acquired pneumonia with no other surgical issues. So I'm not going to explain again. You know, I've highlighted the key things I've mentioned here, and you can come back to it. I just wanted to highlight or draw attention to one thing here, which is usually you would put in the background relevant investigations. In this instance, I've put a implication at the end of the situation section because it's relevant. So I've said he's got a CT proven CAP with no other surgical issues. It's important here because I'm asking for takeover, and it's a big ask of another team. And they basically, right from the start, need to know that I have evidence that it's a medical issue and that I have evidence that there's no surgical issue. So I'd say in this situation, it's nice to kind of include that in this section. And then going on to background, so patient journey right from the start. So Mr. Bueno was brought in by ambulance yesterday with a 2-day history of fever, malaise, and right upper quadrant pain. He was managed with fluids and IV tazocin. A CT to check for cholecystitis showed signs of a right lower lobe pneumonia, but nothing else in the abdomen and pelvis. His past medical history is type 2 diabetes, hypertension, and high cholesterol. His drug history is metformin, amlodipine, and atorvastatin with no known drug allergies. So clearly given the history, clearly given the CT findings, I've said he's been managed, so he's on the right management, fluids and IV antibiotics. So the medical team knows they don't have to kind of rush here to make sure we haven't missed something out. And I've mentioned the past medical history and drug history and the allergies. So then we go on to assessment. So again, observe vitals and impression. So I can say that on examination today, there are coarse crepitations in the right lower zone and a productive cough. His new score is 2 for a 2-litre oxygen requirement via nasal specs with saturations of 94% and respiratory rate of 20. Other observations are normal, and his bloods showed a white cell count of 18 from 16.5 compared to yesterday, and a CRP of 280 from 319 yesterday. So a little bit how this is different to the previous one is we have a new score that isn't 0. And like I said, the new score is an aggregate score. So if it's not 0, then you should explain why, what parameters are contributing to that score. So I'm specifically saying it's 2 because he's got an oxygen requirement, and these are his saturations. And again, I've included respiratory rate because it's relevant to his presentation. Other observations I can just say are normal. It might be useful to say he's afebrile, he hasn't got a temperature right now. And then the other important thing is that I've mentioned the key bloods related to an infection. So the white cell count, WCC, or white blood count, blood cells, so WBC it might be called, and the CRP, and I've compared it to yesterday's results. So they have an idea of whether we're going in the right direction or not, although it's pretty early because he's only had about a day of antibiotics, perhaps even less. Then I'm going on to recommendation, finally, where we are making our request and we'll make suggestions. So I'm saying my consultant feels that Mr. Bueno would be best managed by your team, as pneumonia seems to have driven the sepsis rather than any surgical cause. We've sent 2 sets of blood cultures and a sputum sample, and the results are pending. Is there anything else you would like me to send? So I've been clear about what I want, that they need to take over care in the situation. And I've changed it compared to the bad example where I'm not saying we can't manage it, you guys need to sort out this patient. It's always better to say why the other team is better equipped to manage that patient rather than yours. So that's what I've tried to do in this example. I've also said that I've sent the relevant investigations. I've anticipated what they'd want me to send, and that we haven't got the results yet. And I've also asked, is there something else you want me to send? So an example like this, it would be pretty hard for them to refuse to take this patient. And just in one referral, one call, you know, you've ticked off another job on your list. So that's why making sure that you do it properly the first time can really save a lot of time for you, which you definitely need as an F1. So you made the referral, then what? First thing is you document. Always, you know, we always kind of stress that you need to document things, because if you don't document it, it didn't happen. So document, I spoke to this registrar, his name was this, of this team. and he advised X, Y, and Z, or he has accepted this patient to be taken over by the respiratory team. It's important also for the nursing staff so they know who to call when they've got concerns about this patient, for example. The next thing is you need to complete the requests. If they asked me, do the ECG for that pre-operative patient, I need to do that. If the other team, for example, respiratory team, asks for extra blood tests, technically, if they've been taken over by that team, it will become their responsibility. But it's nice to kind of facilitate when you can. But, you know, obviously you need to remember you are part of a different team. You've got your own jobs. So only if you're free, otherwise they will technically need to deal with it. But usually you'll be able to kind of compromise on it. Third thing is to think about, so you've made your referral, it got rejected. What are you going to do about it? So 3 things. First thing is ask why, not just in your head, but physically ask them why. So at the end of referring to AB, for example, the bad examples, I could have said, oh, well, why? But he gave me all the information I needed. So first thing is that, have you even got the correct specialty? A typical example is calling orthopedics saying, hi, I've got an x-ray. I'm not sure if there's a fracture. Can you look at it? It seems like that would be reasonable, but actually the radiologist is the one who interprets the scans. So you need to make sure you've got the right specialty for your issue, basically. The second thing is insufficient detail. As we saw, Ab asked me for more information and I gave it to him the second time around. Maybe there's further investigations you need to do. And then finally, it might just be a hierarchical reason. So sometimes that's acceptable. For example, intensive care or ITU referrals need to be done by a reg, typically, a registrar, or hire even a consultant. Sometimes it's unacceptable. They'll say, you know, I'm not speaking to the F1, I'm not speaking to juniors, get your reg to call me, or something like that. And in that instance, it can be helpful to kind of explain, you're still part of the team, I'm calling on behalf of them, and it's really beneficial for my learning if you can tell me what went wrong or what I'm missing. But at the end of the day, if you catch someone on a bad day, something like that can happen. If they refuse, you know, it's not acceptable, but you know, ask for their details, ask for their consultant details, which you should do regardless if it's rejected for any other reason. And discuss with your seniors if they're kind of refusing to speak to you just based on your level, because it's not something that should be normal. So you get their details, not to kind of incriminate them or argue or kind of complain about them or anything. It's so that when you discuss with your team, which you should also do as soon as possible, it's so that your seniors can directly liaise with them. They know who to speak to about the referral. So just a quick summary. So make sure you're prepared, know exactly why you're referring, what you're referring for, have the patient details to hand. Then you just need to get on and do it, check you're speaking to the right person, use SBAR. And then afterwards, make sure you document, do the tasks they ask of you. And again, if they reject, ask them why. Sometimes it can help, and you can clarify things. Otherwise, you know, discuss with your team, and they will try and get it resolved. So that's the end of the first bit. If there are any questions, Ab, is there anything?
We've already got a couple.
Yeah.
Whilst more people hopefully think of a couple and send some in, I just wanted to say that example of the orthopedics being used as an image interpretation service definitely happens, and I have yet to be bold enough to say I'm not an image interpreter. I've always looked at the X-ray.
Yeah, no, it happens a lot.
Oh dear, I even had once the med-rate said that. So you know, fracture neck of femurs, you're the orthopods meant to see them and the medics.
Yeah.
I've once had the med reg turn around and tell me, well, you have a medical license, why don't you review them? Didn't really have much of an answer for that. Anyway, so
my answer is always protocol.
nice. It's not if it's in the guide, you can't argue with guidance.
No.
All right. So question number one is from the audience. Do we assume they're ready to listen to the details when you call them, or do you ask them at the beginning? And how do you broach that?
So that's a good question actually. I
Mm.
think usually because you bleep in some hospitals you call them directly to a phone number, but I'd say bleep systems are the standard, I guess, to most of the hospitals I've been to.
Hmm.
So what happens is you send a bleep, so they have a little pager and it goes off and they'll call you back. So typically they'll only call you back if they've got a bit of time on their hands, and are prepared to listen to you. So I kind of say, if I know someone who's really busy, like
Mm.
a cardio reg or something like that, I say, by the way, I'd say the situation bit, because you do take pauses and sometimes they'll say, right, can I just stop you right there? Can you just call me back in 10 minutes or something like
Yeah.
that? So the registrars will definitely tell you if they don't have time and want you to call back later. Yeah.
Yeah. I agree. So when you like I tell them a little bit like I want to talk to you about this like either
Mm.
well person that we want to do this for like
Oh
a
yeah.
like an even mini S bar. And then they'll be like, I'll be like, do you have time for it? And they'll be like, yeah, or I'm in the middle of a crash call, maybe not
Mm.
now, or what have you. All right, I've got
Yeah.
a couple that I had to think of because the we haven't got enough yet. You mentioned earlier about making sure that you refer to the right team members
Mm.
in the team when you do call them. Like some places do SHO, some places do Reg, and what have you. How do you find out which team member you meant to call? Like let's say in the middle of the night.
Yeah. Oh yeah. So I guess in the middle of the night, there's such a skeletal kind of team,
Mm,
that it's hard to kind of call the wrong person
mm,
usually. And I mean, it's the thing is you won't in a lot of hospitals you might not necessarily have a cardio reg overnight or anything like that. I usually use there's an app, which which you should definitely, I think, download when you start working. They haven't sponsored, they haven't paid me to say this or anything like that, but it's the I'm not sure if I'm allowed to say it, but it's the induction app. And it's
we'll
like
bleep it out if it's not allowed.
I've said it anyway now. It's really useful because you can choose hospitals and it gives you all the numbers that you need to call.
Yeah.
But otherwise, you just it's such an archaic system where you basically have to ask around, saying who takes this call, who do I refer to? But then again, I mean, if you call the wrong person, it's not the end of the world because they'll say you need to call the reg instead of me, or you need to call the SHO instead of me.
Yeah.
Um,
I
yeah,
mean,
I
the
don't know.
only thing I might add to that is switchboard. They're really good at saying who to
Yeah,
call.
that's true. That's true. Not always,
Not
but
always.
in general, yeah, I'd say that.
If they're calling anyone's mobile phone, really double check if they're the right person to call.
I would say definitely, especially in the middle of the night. You don't want to be ringing someone, waking them up when they don't need to be. You will
No,
definitely get someone shouting at the end of the phone.
they need their beauty sleep. Oh dear.
Yeah.
Do we have time for more questions, or do you want to go to the next set of slides?
It's up to you. I don't. Do you want me to crack on and then we can just ask the rest, or
I mean, I've got more referrals questions, but I'll just keep them to the end because
yeah,
maybe the
that's
other guys will
fine.
have some more questions. Oh, hang on, wait, we've got one more question before we go.
Okay, go
If
for
you're
it.
bleeping someone and they aren't answering, how often is it reasonable to keep trying, and what's the next step? And probably with that, how long do you leave it between bleeping them?
Yeah, so that's a common issue, I would say. I think it really depends on the urgency of what you need. You know, if there's something super urgent, then you can call them maybe after 2, 3 minutes, 5 minutes. There's also a system where you can fast bleep them through switchboard. So you just say, can you fast bleep this person? And it's a different kind of tone that they get, so they know it's something urgent. Typically, if it's not something, super urgent like that, you can I think I leave probably about 10 minutes, 15 minutes, and then I ring them back. But you do spend quite a bit of time trying to chase people down, and at some point I will sometimes it's not good practice, but sometimes I will just go to them in person. If you know them already and they're quite chill about it, or you catch them on the ward, why not give it a go?
That definitely works in my experience. It's sometimes a lot faster as well, especially if they're really busy. I don't know where I heard a general rule of if you're bleeping an F1, give it 5 minutes, bleeping an SHO, give it 10, bleeping a reg, give it 15. There's nothing
Huh,
backing that other than experience.
interesting. I've not heard of that,
All
but
right, cool. Should we
cool.
go on to the next set of next presentation then?
Yeah, so I'm just gonna take this off share so I can open up the next one.
In the meantime, while she does that, guys, don't forget, Fatima would love to keep answering your questions. Go ahead and send them during the slides. We're about to go into requesting scans, and then also, hey, immediately after, if you think anything else, go ahead and put it on the Facebook group, and maybe she'll be able to get some more information to you. And then there's also the website, mindthebleep.com website that you can refer to that has a lot of this information as well. Oh, we're screen sharing. Okay, there we go.
Don't look at my million tabs open. So next bit is requesting scans, and I have structured this in a similar way to referrals. There is clearly some overlap. It's not deja vu, but I just used similar slides so that I can just highlight the key differences between referrals and requesting scans, but it is pretty similar. So again, same kind of structure to this talk: introduction, why is it important, and then making the request. Pre, during, and post, what are the things you need to think about? So it's in the name, requesting scans. It is a request and it is not a demand. You, your team, anyone from your team who's making a request for a scan, you need to remember it's not kind of a delivery service. Your radiologist in the hospital needs to authorize and accept to do the scan. So bear that in mind when you first start working. Again, this can be done paper, electronic. It just depends on the type of scan and which hospital you're in. Most of them will be electronic, and again, the concepts and the principles are similar. So why is it important? Again, it is part of your job, and typically it will be things that your seniors are asking you to do on the ward rounds, or when you're covering the wards, you will be requesting things kind of independently, like a chest x-ray or something like that. Nothing too high tech. Again, it's important for patient care. So it can identify the cause of a patient's condition. It can help rule out things, like in our example with the chest infection. So it identified the cause of his sepsis as the chest infection, and it ruled out surgical issues. So it was useful in that sense. It can also help with planning. So pre-operative planning, sometimes they'll get a scan. It helps them to appreciate the anatomy better. Or even for MDTs, multidisciplinary teams, when they're trying to manage things like cancers, so when they're trying to decide on treatment plans. It can be challenging, possibly more challenging than making a referral, because it's usually a consultant radiologist that you'll be requesting and calling. And personally, I will say that I managed to get an SLE for my e-portfolio for requesting scans. I was obviously not doing a very good job of it over the phone with my reg in the same room, and he gave me some good feedback after that and got something for it for my portfolio. So there is a silver lining, even if you're not perhaps doing as well as you should. So requesting a scan, what you need to make sure you've got sorted before the scan: know the rationale. And there are two key questions you need to ask yourself: why this scan and why for this patient? And importantly, is this scan actually going to change management? Because if it's not, I can guarantee you it's not going to get accepted. If it's not going to change your management plan, what is the point? You're putting a patient under unnecessary radiation, you're using up valuable resources. The radiologist is not going to accept it. So again, make sure you've got this clear from your seniors, what exactly they want and why it's important. Next thing is the choice of the scan. Make sure you've got this correct. So it's something you'll pick up on about what scan is appropriate for each condition. But regardless, your seniors will be happy to kind of clarify exactly which scan they want. Third thing is to prepare. So again, details of a patient in the same way to making a referral. And then also preparing the patient. So that's kind of, I'd say, double faceted. So the first way in which you prepare the patient is that make sure they actually know they're going for a scan. It seems really obvious and really simple, but the last thing you need, and this happens fairly often, I'd say, is you have a patient, you organize the scan, you waste a lot of time trying to get them a slot, and then porters come to take the patient, and the patient says, oh, I don't know what this is about. No one told me I'm going for a scan, I'm not going. So you've lost your slot at that point. It's not useful. If they haven't been told on the ward round that you're going for a scan, and after that someone's decided they need one, someone just take 5 minutes to go and tell them you're going for one. It will save you a lot of heartache. The other way in which you prepare the patient, which maybe is not as obvious right now, but when you speak to the radiographers to organize the scan, sometimes they'll give you specific requirements that they want of the patient to prepare them for it. So for example, if you're having an abdominal ultrasound to look for gallstones, they'll say, make sure they haven't eaten anything in the past 6 hours so that they can visualize it better. So again, something that you'll be told by the radiographers when you organize the scan, but you will pick up on it with time as well. And you can implement it even before you make the request. Tell the patient, don't eat anything from now, so that you have more slots available to you. Otherwise, they'll be done right at the end of the day, if even that. So making actual request. Again, it sounds super obvious, but check you have the correct patient when you're making the request. It really is easy to kind of be checking loads of patient records on electronic systems and end up requesting a scan for the wrong patient. When I was an F2, I actually had a colleague who did that, requested an echo for the wrong patient. The echo actually got done, surprisingly. And then we were left with a report. Obviously my colleague had to go and tell the patient, I'm really sorry, you didn't even need the scan. Thankfully in that situation, there were there's obviously no radiation effects, exposure, and also the results of the report were normal, thankfully. But you can see how that can become a big issue if, they were exposed to radiation, plus the fact that you might have picked up on some abnormalities. So check, double check, triple check. We'll go through some examples in a minute, and you'll see that they loosely follow the SBAR framework, but it's much more condensed, only very specific and relevant information to a radiologist. They don't need to know as much as a team that you're referring to needs to know. So we'll go through that in a second. The third thing is that when you request scans, there's usually a little drop-down box where you select how urgently you want the scan. And it can be like routine or urgent. And in some places, they'll also have emergency. Emergency typically used by A&E or for, extremely unwell patients. But the urgent ones you will probably use most often. That is the standard, I'd say. But again, check with your seniors. When they tell you they want a scan, tell them exactly what scan is it, what is it for, if you don't know already, and how urgently do you want it. So I'll do a couple of examples. So first example, you have a patient with renal colic. So If you're not aware, your team might tell you anyway. The first line scan is a CT KUB, kidneys, ureters, bladder. It might be CT urinary tract or something like that, but it's not a urogram, but just double check that you've selected the correct thing on your system. And the request will probably read a bit something like this. So I'll read it out in case you can't see it on your screen. So 48-year-old male with sudden onset, intermittent, left-sided loin to groin pain. Past medical history of previous left-sided renal stones treated conservatively. On examination, tender left lower quadrant, plus. Urine dip, trace of blood, nothing else. And then I've got query, urinary tract stones. So again, I've highlighted the key things that a radiologist is looking for, which again, you'll pick up on. So unilateral, as stones usually are, renal stones. I've said it's left-sided. I've put in that key phrase, loin to groin pain, and also a key investigation result. Urine dip shows a trace of blood. And then always end it with a query of what your top differential is, maybe if you've got more than one differential. So again, you can see it's much shorter than S-bar, but kind of ticks off the same domains. Second example, appendicitis. And I'm going to say this for a young female because it makes a difference. You might choose different scans for other patients with different kind of sex or age. So for a young female who's of childbearing age, so you do typically do an ultrasound because you obviously don't want to irradiate their pelvic organs where they have their ovaries. So ultrasound, lower abdomen or pelvis, TA/TV, trans-abdominal/transvaginal. And the request is as follows: 22-year-old female with a 2-day history of worsening right iliac fossa pain. Last menstrual period 2 weeks ago, regular 28-day cycle, no menorrhagia, no dysmenorrhea, no PV discharge, and no past medical history of note. On examination, guarding, right iliac fossa is tender, plus. Bloods are unremarkable. And then I've got 2 possible differentials: query appendicitis, query ruptured ovarian cyst, because she is mid-cycle. So they can mimic each other quite well in this age group. And some consultants will advocate for always getting an ultrasound for these kind of patients, because you never know. No point in kind of putting them under a surgery if they don't need it. So those are two classic examples, I'd say. So you've made your request. This is a bit, the things I've highlighted here are a bit different to the referrals slides. So the first thing is you need to make sure you get it done within a suitable time frame. You might have clicked urgent, but the radiologist, everyone's got urgent scans, and the radiologist's got other things to do. They might be doing ultrasounds, they might be reporting scans. So it comes up on their list, but by the time they get to your scan to try and vet it, which means authorize it, that's what vetting means, it might be too late. So I'd say if you've got an urgent scan, definitely call the on-call radiologist and speak with them and get it vetted over the phone. That's after you make the actual physical request. Once they've accepted to do it and they've ticked it off, now you need to get an actual slot. So you call the radiographer, and that's the team that technically performs the scan, and ask them kind of, I've got this urgent scan, it's been vetted by the radiologist, can you please tell me when it might be able to happen? And they'll give you a time slot usually. So you think you're covered, but not yet. So they've given you a time slot, but you still need to check that it was performed. You never know, maybe another emergencies come up and they take priority. Maybe the porters are in short supply and there's not enough to come and take your patient. So you need to check periodically throughout the day, has it been performed? And then once it has been performed, really important, you will have images usually straight away after it's been performed or not long after. The report might take some time, but regardless, it is your responsibility as the person who requested it the team that requested it to check the images and the report, because one might miss something that the other hasn't. Obviously, if you're, finishing your shift, then definitely hand over to the person on call. By the way, I've requested this scan, it's going to be performed. Can you make sure that you check the images and the report? The final thing is, again, sounds obvious, definitely inform the patient of the results. So, obviously there are exceptions, but in general, patients had a scan, they're probably worried, they've got no idea what it showed. You go and tell them, by the way, your scan showed appendicitis, so we're going to prepare you for surgery, etc. So definitely make sure someone goes and tells them. Third thing is managing rejection, and this is similar to referrals. So ask why again. If it's the wrong scan you selected, if you've had the correct information on the request, the radiologists are really good at just switching the scan type. Have you got insufficient detail? You can clarify that over the phone. And it's really important for a radiologist to have the right information and know what you're looking for, so that they can, they can interpret the images with some context, and to make sure they, report on the thing that you're actually worried about, rather than everything else that might be normal. Maybe they want another investigation before you do a scan. And again, it might be hierarchical in the same way, either unacceptable, or sometimes it's it's local policy where, for example, I've worked in hospitals where only a registrar can request and vet scans, CT scans overnight. So check what the policy is in your hospital. I'm sure you'll be told as well. But that might be a simple reason why it was rejected. Again, ask for their details, the consultant's name, and discuss it with your team as soon as possible. Let them know, say, I put in this request, I told them this, they still rejected it. Perhaps they said, I want to speak to your senior. And then they can call each other and sort it out. So just as a quick summary, make sure you prepare. So make sure you know the rationale, ask, and you've got the correct scan type. Then you want to do the actual request, check you've got the right patient, like I said, and include relevant information. After that, make sure it gets done within a suitable time frame, and definitely check all those things we talked about. Again, if it's rejected, ask why, and if not, discuss with your team. So that's the end of that. Obviously, we do these webinars for your benefit. So to try and improve them every time, to try and make sure they're kind of adapted to what you think is best or what might help you the most. We really appreciate if you give us feedback, specifically what you think was good or to carry on, we should carry on doing, what you want us to improve, because we really do check them and try to implement for the next webinars. And again, you'll get a certificate for sending us feedback. Use either that QR code or the link I've put up. We'll put one in the chat as well. And again, it's something we also need for our portfolio. So I'd be very grateful if you could give us feedback. I'll keep that slide up there for now, but if we've got any questions, maybe Ab can
Mate, they're flying in. I'm being swamped with them. Are you ready?
Yeah, okay. I'm
All right,
ready.
I think Nero has tried to answer one, but I love this question so much. It highlights how much jargon medics use. I wanted to put it towards you as well.
Okay.
So
sure.
one person asked. So if you go back to the appendicitis, don't go back to the slide. But the idea was the appendicitis referral with the where you said right iliac fossa pain plus plus plus, right iliac fossa tender, sorry, plus plus plus. So they asked the plus plus plus. Is that just the intensity of pain, and is that plus 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 out of 3? They're just wondering because they thought when you ask them a patient about pain, you rate it 1 to 10, and I thought that was such a good question.
That is such a good question. That is true. You can put, I'd say usually when I'm mentioning, so let me just say, I was tried to use abbreviations and all that things because I didn't want too many words on the slide. So fair point. I think out of 10 rating pain. So I do sometimes when I'm giving the history, say pain rated, whatever it is, 8 out of 10 or something like that. But when I'm doing the examination, so pain is their kind of subjective measure. Tenderness is when you're, well, I use it for examination findings. So if they're kind of jumping off the bed with pain, then I'd put more pluses. It's a bit arbitrary and subjective from, you know, the referrer or examiner's kind of point of view, how many pluses you put. But sometimes it conveys a sense of urgency that that you need when you want a scan pretty quickly. I
If
don't
you
know. What
go,
do you think, Ab?
if you go above three pluses, you're having a joke, mate. All right, 3+ is the max. I've never
Three
seen
pluses.
anyone say 1+ or 2+ though. Like,
Yeah,
because
I'm not. Yeah, that's a good point. Yeah.
you don't really like when you say tender, you say tender. If you say really tender, it's really tender. You don't try and downplay your symptoms too much just because unless there's like clinical like they're not sure what the problem is, and that's when you want to say, hey, it's really obscure, we don't know. But
Yeah.
generally, if you go down a pathway of saying, look, it's really looking like this, we need a scan to actually find image it, then you do the
Yeah.
pluses.
Yeah.
There's a
Exactly.
second one as well, actually. So you did go over this, but they just wanted to just go over again the pathway specifically for vetting and then getting the slot. So you talk to the radiologist and then you talk to the radiographer. Can you just go over that again?
Yeah. Sure. So you make your request on usually a computer system. So you've opened up that patient record. You've selected which scan you want. You've typed in what your request is, like one of the examples, and then you've selected the urgency, accept request, it's sent. So the radiologist, they have a separate screen where there's a whole list of all the requests that everyone in the hospital has sent them. And what I was saying was that they've obviously got a long list to go through. By the time they get to yours, it might take ages. So as I said, it's a request and not a demand. So they have to authorize it or vet it. So what you do is you've got an urgent scan, you've sent the request, you need to make sure they accept to do it. So you call the radiologist uh, and you speak to them, you say, hi, this is the patient hospital number. I just want to vet this scan. You just basically discuss the patient. If they want a bit more information than the request, they'll ask for it. And then they'll say, right, okay, I've vetted it. So they're happy for it to go ahead, but they won't necessarily know what time it might happen. They're not kind of handling that logistics side of it usually. So I've got it vetted, but I still don't know what time it's going to happen. I want a bit of information about how quickly it's going to happen. Then I would call the radiographer. It is a bit of a process, I'll accept that. But then you call the radiographer and they will give you a time slot. Sometimes they might give you a time slot that's way too late, in which case you kind of go back and forth calling the radiologist saying, oh, they gave me a really late time. Is there any way you can bump it up? Because they do have ultimate like prioritization rights. But typically, you know, make the request, call the radiologist, call the radiographer. I don't
Yeah, I
know,
hear you.
Ab, you want to add anything or?
I mean, you're very right in terms of the radiologist who's actually the radiologist is the doctor, the radiographer
Yeah.
has not got a medical license. They have their own training, and they do. The radiologist does have last say in terms of when they go. But no, I agree with everything you said there. There's one last question they had, and then I might have a couple more depending on how much time we have. Estimated time frame of getting things done. I know that's really subjective based on which hospital you're at, but could you give us a time frames based on your own experience?
Do you mean like from requesting to?
To get, why do we say to getting the images back slash getting the report back? Because they're two different things. And the
Okay,
specific example was between chest X-ray, CT, MRI, which are
okay,
three very, very things.
fair enough. Yeah, yeah. So it's it varies. It really does vary between hospital to hospital. So I've been in hospital. Typically, I'd say, you know, between the imaging modalities, X-rays usually happen the fastest. Then CT scans and then MRI scans. That's what my experience has been. Some places you request an X-ray and it just kind of happens so quickly you don't. So let me just clarify, for X-rays you don't need to get them vetted usually. As for in my experience, I've never had to vet an X-ray. But so with X-rays, I don't bother calling the radiologist. I call the radiographer only if it's a portable chest X-ray, and I'm obviously that means I've been in a situation where the patient's too unwell to come down for an X-ray to the department, and I need a portable one as soon as possible. So I call them for that, and X-rays are pretty quick, like within a couple of hours usually. Sometimes they even do them sooner than we want them to. So in that case, then I'd let them know and say, can you make sure you do it at this time? But yeah, so that's for X-rays. CTs, it is variable, but you tend to call them and try and get it done. CTs, I would say, typically done on the same day. Even because they can still do those kind of things overnight. Ultrasounds are a bit different. Same with MRIs, they tend to have opening hours. So ultrasounds need to actually be done by a radiologist or a trained radiographer, and that's usually between 9 to 5. So if it doesn't happen by 5 o'clock, it's not going to happen that day, it's going to happen the next day. MRIs take probably the longest. I mean, sometimes they'll say next week. It just depends on how many slots they have available. But you wouldn't usually be requesting that many MRIs anyway. So yeah, I'd say if you kind of chase them, they will get done within a reasonable time frame.
I will agree that MRIs are the bane of my existence. I mean, sometimes it's so weird. People are just admitted because they need that MRI, like query-quarter equina cases, under the medics of all things.
That's true.
So it's yeah, the waiting times do get a little bit difficult for them. The only thing I'd want to add about vetting X-rays is the ones that require contrast. So a gastrograph and follow through, because they're giving like sometimes they do need that vetting, some based on trust guidance, I guess.
That's true.
What else? So do we have any more questions by these guys? Another question for CTs. You'll likely need their renal function, right? Are there any other scans that typically also need an up-to-date biochemistry?
So renal function is important for CTs with contrast.
Yeah.
And I think it's usually they want an EGFR above
45.
Was it 45?
Yeah.
MRIs also, again, they use a different contrast medium though. I think typically EGFR more than 30, but you'll have to double check that. Things without contrast don't usually need an up-to-date biochemistry.
And the only other biochemistry that you care about is your beta HCG in pregnant ladies, I assume, with
Well, yeah. Well, they ask anyway. Like with abdominal X-rays, for example, there's usually, so when you make a request, sometimes there's like a menu you have to go through. So like, is this patient pregnant? Yes, no, unknown. And then, sometimes even it will be like, when was their last menstrual period, and you click a date or something like that. So whatever they need to know, they will have it on the automated system.
Got it.
But yeah,
hang on a sec. I'm seeing another question here. If the scans are not done on your shift, then we will write in handover and mention. Okay, so this is to do with when you request a scan out of hours. And actually, I had a couple of questions about that as well, because I think that's really important. But they specifically asked if you request a scan that's not done in your shift, what are you meant to do? Do you write off in the handover? Do you mention it somewhere? What do you do?
So if you know the scan isn't happening that day, it's going to happen tomorrow when you're back on, then you can just sit tight. There's nothing to hand over, I guess. If you know that the scan is going to happen that day later on, or before your next on the next day or whatever it is, then you should definitely speak to. So there's I don't know how much experience med students have of the kind of handover processes that happen, but usually at around 5 o'clock, there'll be a barrage of calls to the poor F1 who's on ward cover, and you will be making one of those calls, and you'll say, hi, this is the background, again, similar to SBAR, this is my patient, I need you to trace this x-ray, make sure you look at the scans and tell them what to look for and what to do if the scan shows a particular abnormality. So you need to give clear plans to your F1s. The quality of these handovers, you notice at the start of F1, is not as great as, you know, a couple of months into the job. But also don't be afraid if someone's handing that over to you, say, what exactly am I looking for and what should I do if it shows this? Because you need a plan. If it shows something abnormal, you can't just kind of sit there and, you know, wonder what to do.
Especially if you're the 5 p.m. to 8 p.m. or 9 p.m.
Yeah,
kind of guy.
definitely.
Because then if the scan gets done overnight and you're handing that over to another person, you haven't even requested the scan and you don't know
Exactly, that's true.
anything, then it's so painful for the guy overnight, you know?
That's a good point, actually. So if you know a scan, for example, is going to happen overnight, so it won't even be the person you're handing it over to, you still have to hand it over to them. So you say, hi, this person is going to have a scan overnight. It's not going to happen during your shift, but make sure you please hand it over again to the night person.
Exactly. Now there's there's a couple of questions I had about, just to try and make it meaner. Niraj, jump in when I'm meant to shut up. But what about when you're requesting things overnight? Is there anything else to reconsider, maybe regarding vetting or what have you?
So yeah, as an example that I gave, I worked in a hospital where you as below reg, you can't request and vet CT scans, for example. And some places will have kind of, there's an outsourced radiology kind of organization that you call through the switchboard. So again, you need to know what the system is in your hospital. Is it the same radiologist's number as during the day or on-call radiologist, or is it this external number that you have to call through switchboard? So once you know, then you can make that call. But they will, if it's basically only a reg that's allowed, I mean, I wouldn't bother kind of wasting your time calling. Your reg needs to do it. They'll call because they'll ask for your name and your position. So yeah, that can sometimes be a little bit of a snag and it's frustrating, but that's just how things work.
Yeah, it's a pain in the backside. I agree. All right, so Niraj said I'm down to my last question. I'm not allowed anymore, and then he's gonna pull me off the air.
There you go.
I'm having difficulty deciding the last question, mate. You know what? Why don't we go with the most difficult one, I think, which is gonna be very
Thank
fun
you.
for you. Imaging in unwell patients, i.e., those that are demented, non-compliant, something like that. Let's say you want to do a CT scan for someone and they're just not holding still, where they got a tremor. What do you do?
That is a really good question, and it's something that is not easy to answer. I'm gonna say, this has happened a few times. You need to think about the technical difficulties that a patient might experience with having a scan done. So it's not just, you know, dementia and that kind of thing. It's also things like, are they able to lie down flat still? If they've got loads of pulmonary edema, they're not going to be able to breathe, for example. So that's one thing to think about. Your seniors basically will decide if they'll notice that this patient is not going to sit still. Sometimes they'll send them down and they'll just get sent right back up saying we couldn't do the scan because they're too demented, or you know. Sometimes those patients have kind of intervals where they're not as agitated, but other things that you can use, although I would discuss it with your seniors, certainly as an F1, is you know, something to just calm their nerves a little bit just before the scan. uh, something to help them relax. But again, as an F1, I wouldn't have been comfortable to make that decision myself. Like I would not make that decision
I
myself.
love it. We have two surgical juniors discussing how we'd give lorazepam to elderly patients with no
I,
geriatric
I
doctors in the
didn't
room.
say that, but
That's exactly what you're
sometimes
alluding to.
no, but sometimes, but not even sometimes a bit of chlordiazepoxide for patients who are, you know, you've got a regimen going and you just give them a small PRN dose, well within the guidelines, and send them down for the scan. Sometimes that's what you need to do.
Exactly. Very, very true. And another thing to keep in mind would be that the hospital guidelines in terms of who's actually allowed to give that medication and where. Do you give it on the ward? Do you give it in front of the CT
Good point.
scanner,
Good
what have
point.
you? I see Niraj, which means I think we're about to be pulled off stage. Any last words, Niraj?
Just about. No, well, thank you very much, Ab and Fatima. I think that was I think this was one of our most anticipated webinars, and you definitely lived up to expectations. So thank you both very much for your time. We've got lots of very appreciative comments coming in. Somebody's just called both of you brilliant. So guess you're doing something right.
Or they're being very charitable.
Or that. All right.
Oh, I just wanted to mention actually really quick. Sorry, Niraj. I know
No
you want
worries.
this to. Just for the referrals, there's an article and there's cheat sheets which Niraj has put up on the chat in case you haven't seen that. Cheat sheet is really useful, so it breaks it down by specialty, the important things you need to let them know. And there's also an article for requesting scans. Again, he's put it up on the chat. Sorry, I should have mentioned that.
No, that's fine. That's all in the chat. And guys, keep your questions coming. We'll get Fatima or Ab to continue answering them until they're tired of answering questions.
Fatima, definitely Fatima.
Great. Well, thank you all very much, guys. Thank you. Bye. Join us at the next webinar. Just go onto our Facebook page, onto events, and click going or interested so that you're notified when we next have a webinar coming up. All right.
Cool. Thank you.